So let me do that. All right, so Dr. Kyle Lynch earned his medical degree and master's degree in medical humanities, compassionate care, and bioethics at Stony Brook University School of Medicine. He is currently an assistant professor in the Department of Obstetrics and Gynecology at the University of Rochester Medical Center, where he serves as the department's education specialist. In this role, Dr. Lynch designs, develops, and implements educational initiatives to benefit learners at all levels along the medical trainee practitioner continuum. In addition, Dr. Lynch provides his expertise on issues related to HIV prevention, LGBTQIA+ healthcare, and providing affirming care through the New York State Department of Health Clinical Education Initiative and through private consultation. Dr. Lynch is also a proud co-editor of the forthcoming book entitled From Margins to Mainstream, A History of Transgender Medicine in the United States. So with that, please help me welcome Dr. Lynch. And Dr. Lynch, I will hand it over to you. Just a quick announcement, please, as you're entering or as you're joining, please utilize the chat to send us your email address so we can send you some CME information.
And thank you so much, Maha. And I don't think I see Scott, but I definitely owe him some gratitude too for connecting us. I'm really grateful for the opportunity to talk with you all this evening. Happy Pride. It's always great to time it, although of course, Pride lasts all year round. So what we talk about tonight will hopefully stay with you well beyond the end of June. Before we go any further, I do want to also just take a moment to clarify or to emphasize that I'm here as part of the New York State Clinical Education Initiative, which we abbreviate CEI. But if you're not familiar with it and you're in New York State, I just really want to let you know about it. It's this great program that the Department of Health AIDS Institute funds to allow our medical professionals to get continuing education for free on topics related to sexual health, HIV treatment and prevention, hepatitis B and C, drug user health, and anything sort of in that ballpark. There's phone numbers that you can call for consultation if you have, maybe an STI that's resistant to treatment and you're trying to figure out the right thing to do. So CEI is a great resource. Jessica is here from CEI, and so I'll ask her to put the link to the website in the chat. But I want to thank very much the New York State Department of Health for not just being different from other states and not, putting out propaganda against trans healthcare, but actually taking steps to provide resources so that we can share actual accurate information in sessions like this. So thank you very much to CEI. So as Maha mentioned, my name is Kai. My pronouns are he, him, his. And what I'd love to do for the next hour is talk about LGBTQ plus healthcare and how it impacts you in your practice and why you should care and why it might actually change the way you approach certain patients or change the conversation. I am going to ask you for your participation because I can't even tolerate listening to myself talk straight for just 40 minutes. So if you are willing to turn on your cameras, I would love to see your faces. I'm also going to ask you to unmute or put answers in the chat because I'll be asking a lot of questions. We're going to use the old standby chalk talk with a little bit of a 21st century twist. So I'll be sharing my screen and doing sort of whiteboard drawing as we go through this together. So I'm going to give you a moment. I'll tell you a little bit more of where I'm coming from, but then I'm going to start asking you things, and I really hope you all don't leave me hanging. So I, over the course of my life, have come out twice. The first time I came out was as a teenager, and I came out as a lesbian at that time because I had a girlfriend. I was madly in love. We were going to be together forever. That didn't happen. But I came out as a lesbian, and the reason I did that was because it was the best thing available to me at the time. It seemed to check at least some of the boxes of why I felt different from my peers and how I could best, mold myself into society's standards. Then I grew up a bit. I graduated from medical school. I got married. And then I realized that that really wasn't the end all be all, that wasn't going to fit forever. And so I came out again as a trans man. And so now for several years, I've been very happily living as a man and, feel more at home in my body and in the world than I ever did before. I'm thankfully still married to that wonderful woman, and I get to still be in academic medicine, which is wonderful. And now that I live in these sort of two worlds, the LGBTQ plus community and also the academic medicine community, I know firsthand that both of those groups have very particular language and customs and cultures, and it can be a little bit hard to break into them. Our academic medicine jargon and acronyms is scary to outsiders, just like the LGBTQ community. And so I feel it's partly my responsibility to help sort of bring those two groups together and start some conversations and make it a little less scary for both sides. So that's what we're going to try to do this evening. So again, please participate and talk to me. That's the best way for me to know where you're at and what I can do to help you get to know the LGBTQ community a little bit better this evening. So I've shared my screen, and on it is an acronym, which we're famous for in medicine, SOGI. Can anyone tell me or guess about what SOGI stands for?
Sexual orientation and gender identity.
Yeah, thanks, Emily. That's exactly right. So sexual orientation, and by the way, as a member of the medical community, I hope you will all tolerate my terrible handwriting. It's still not good, and it isn't going to get any better. Okay, so sexual orientation and gender identity. And we see this abbreviation used frequently in the data collection world. So you can see it in research and also in medical charts more often these days. All right, so now that we know what this stands for, and this isn't meant to be a trick question, but can someone give me a brief definition of what sexual orientation means? I know many of you know, so someone just throw something out there.
Kind of like who you're attracted to.
Yeah, exactly. Thank you so much for weighing in. So sexual orientation is all about, if this is you or a person, it's how we feel outwardly towards other people. And this can be predominantly sexual, romantic, or both. And we're really not talking about like an individual slice of time, like how you feel exactly right at this moment in terms of your attraction towards other people. You might be someone for whom your attractions kind of really ebb and flow. Sometimes you're drawn to more masculine people, sometimes more feminine people, or maybe you're someone who's had the same exact type since you first went through puberty. Either way, when we talk about sexual orientation, we're talking about the general patterns over a long period of time. So your general pattern of attraction towards other people over the course of your life. So what are some of the terms that people have developed to describe their sexual orientations to others? Again, not a trick question.
Lesbian, gay,
Gay, straight, lesbian, queer.
Fire. Right. So these are probably are pretty familiar to you, and we don't need to belabor them, but these are all sexual orientations. These are all terms that people use to describe patterns of attraction towards other people. Right. So gay, classically meaning someone who identifies as a man who's attracted predominantly or exclusively to other people who identify as men. It sometimes is used sort of as a catch-all term or an umbrella term for anyone who isn't this. Straight. Straight, of course, being another term for heterosexual. And it's important to note when we say straight and heterosexual, these are still really considered the default by society. Right? It's very rare. In fact, I've never actually heard of it for someone to come out as straight. We are all straight until proven otherwise in our society, and hopefully that's changing over time. But we don't want to assume that people are straight as the default in medical practice and in our lives. Lesbian, another word that you're probably familiar with. The classic definition is people who identify as women who are attracted predominantly to other people who identify as women. And then queer is, a little bit more of an interesting term because, of course, it used to be a slur. And so for many people in the LGBTQ community, it still sends a shiver up their spine because they used to maybe associate this with then abuse. And so it can be a little bit of a polarizing word. For some people, it still is not a word they're comfortable using. And for others, it's the exact opposite. Because it used to be used as a slur, it's been reclaimed, sort of picked up and worn as a badge of pride. Like, you used to call me this, you used to think this was wrong. I'm proud of who I am. You can't make me feel ashamed. And it can be used as, again, a sort of an umbrella term for anyone who exists outside of the mainstream, which in this case would be straight. Have we heard any other terms, maybe ones that you aren't as comfortable using yourself or aren't totally sure what they mean?
Pansexual, asexual, aromantic, and I prefer not to actually give you one because I'm still questioning.
Okay, so pansexual, asexual, aromantic, and questioning. So so pansexual is, I think, becoming more and more common, and it is, and some people associate it closely with bisexual, and some people really separate those out. But really, it's the sort of recognition that you don't have to be attracted to one type of person. You can be attracted to different types of people. And so bisexual used to be a commonly used term because bi, meaning two, was the way of expressing that you're attracted to both men and women. But as our understanding of gender has evolved since, we recognize that you can be attracted to lots more types of folks than just men or women, or people who identify as men and women. And so the term pansexual has taken up a lot more prominence. Asexual, sometimes abbreviated ACE, is a community that we unfortunately forget about all too often and deserve recognition. So this is a community of folks for whom sex isn't the primary driver in forming relationships. Sex may or may not be involved in their romantic relationships. They may have very long, serious, committed romantic relationships over the course of their life. It's just that sex is not the predominant, driver. It's not how they experience that sort of partnership. Aromantic is sort of similar, but on the romantic end of things. And questioning is, a really good one. And I'm really glad that someone said that, because that's rarely something that someone throws out there. But it's a great one. I think a lot of us spend more of our lifetimes in the questioning phase than we maybe would like to admit. So questioning is a fine place to be. And so these are all terms that are used to describe sexual orientation, which once again is all about how I feel towards other people. So what about gender identity? Can someone give me a brief definition of what gender identity is?
Just what you identify with.
Can you say that again? I didn't quite hear you.
It's how you identify yourself.
Yeah. And something that I really like that you said was that you talked about it being a self-definition, right? So in contrast to sexual orientation, which is how I feel towards others, gender identity is how I feel about myself, how I understand myself. And so it's a very personal thing. And unless you're literally in someone else's head, you cannot know just by looking at someone what their gender identity is. Awesome. So what are some terms that people use to describe gender, to tell you what their gender identity is?
Cisgender, transgender, non-binary.
Okay. Yeah, I guess we could also
Male, female,
What's that?
male, female.
Okay, any others?
The terms
Genderqueer.
keep evolving. But they've gone from gender nonconforming to gender queer. And there's a few other new terms out there. And I think exactly who said it's how you identify yourself. And a lot of people just don't want to be labeled. So those are the people that would be most helpful if you could tell us the best way to ask so that we can be very inclusive.
Yeah, thank you so much for that, Lisa. Good point.
And then in chat, Mary responded also, and she said agender.
Right. And then I think the ones that I typically hear first, this is sort of, I can already tell an advanced group, but usually I also get man and woman in there. Okay, so I've purposely tried to draw a little bit of or leave a little bit of a space between this group and this group. Can someone try to maybe tell me the difference or why I might have separated those?
Male and female are more like sex characteristics, whereas the upper ones are more like cultural characteristics of gender.
Yeah, beautiful. Exactly. So male, female are distinctions or designations that medical people place upon us. Usually we refer to this as sex assigned at birth. So, when you deliver a baby and you take a quick look at the genitalia and say it's a girl, it's a boy, that is you assigning a sex to a new person. And so we use the terms male and female. Some other terms you might hear like intersex or disorders or differences of sexual development also fall in the sex assigned at birth category. Whereas gender is what I think I heard a cultural or social structure, societal structure, right? So one example I use sometimes is, when I started to live as a man and feel more comfortable, one of the things that I was drawn to is wearing a tie. And it wasn't just because that's what people expected of me. It's because it felt good to learn how to tie a tie or, to shave, those sorts of things. My body did not, it was not something that was in my genetic code that I was destined to wear ties. That's the kind of thing that society taught me. And I kind of have grown up and associated my masculinity with wearing ties. So that's different than what my body was destined to do based upon the various hormones and signaling pathways that are in my body. There's a difference between what my body's going to do biologically and what I feel I must do or I want to do because of what I've learned from society is normal for a man versus for a woman, right? And so the reason I just make this designation is because some of the terms that you all threw out there are really hard, I think, for people to understand and also explain to others if you don't understand the designation or the distinction rather between gender and sex, right? So like cisgender, transgender, non-binary, these are all much more easily understood if you recognize that gender identity and sex assigned at birth are different things. And in particular, that gender for some folks lines up super nicely with sex assigned at birth, right? So you're assigned female at birth and now 40 years later you identify as a woman. Those things line up neatly and you can kind of go with the flow of society. And because those things are sort of on the same side of our mutually constructed understanding of gender and sex, you might identify as cis. But when gender and sex assigned at birth don't always line up, like me assigned female at birth but identifying as a man, that's when we use a term like trans or potentially non-binary for someone who doesn't want to pick a gender or feel limited by only two options. I love something I just saw in the chat, which is that biology is a construct, which is exactly where I was going to go next. So when we use terms like male, female, intersex, and differences or disorders of sexual development, what kind of values or what kind of elements in the body are we relying on to help us determine whether someone gets labeled male, female, or intersex? What goes into the term sex assigned at birth?
Are you asking whether they have a penis or a vagina?
So external genitalia, that definitely goes into it. What else?
What their parents name them?
Interesting. So name, I think I would argue is more in the gender camp, because something that we've all agreed to is to use names to help other people learn if we are men or women, right? So a lot of people, when they transition, they might change their name because we've gendered names in our society. We all just have kind of accepted that Rachel belongs to women and Matthew belongs to men. And so choosing a name for an infant can actually be a practice in assigning a gender or anticipating a gender for a child rather than how we determine sex assigned at birth. I see someone in the chat said X and Y chromosome. So looking at a karyotype and seeing XX or XY. What else? What else goes into this concept we call sex assigned at birth or sex?
Internal reproductive system or organs, I mean?
I think I heard internal organs.
Yes.
So uterus, ovaries, fallopian tube, prostate, that sort of thing. Totally. What else?
Hairstyle, hair distribution.
So you just said two things, and I'd say one of them belongs in the gender camp and one of them belongs in the sex assigned at birth camp. So we've got hairstyle and we've got distribution of hair. So I would say hairstyle is something that we choose, and we as a society determine what is masculine hair and what's feminine hair. So hairstyle, I think, would go up in the gender expression, how we express our gender, but distribution of hair or secondary sex characteristics would fall into the biological sex camp. Sure. How does our body know to develop hair in certain places?
The hormones.
Hormones?
Yeah, hormones, right? And hormones are signals, right? So in order for a hormone to be effective, it needs to both exist at the right concentration, and it also needs to have a receptor that knows what to do with it, right? And because we're all in the medical field, we could go line by line here for all of these different elements of sex, and we could recognize that differences exist, right? So not all external genitalia is formed the same way, depending on, I mean, everyone has their unique external genitalia, but during embryonic development, the way that external genitalia get formed can be influenced by different factors, environmentally and otherwise, right? And certain teratogens. Chromosomes, although XX and XY are by far the most common sex chromosome arrangements, we all know that there are things like Turner syndrome and XO or XXY or XYY, right? So even that, there's a little bit of a range. And then we know internal organs develop or don't develop because of the tissue responding to certain signals. And there are plenty of things that can lead to alternative arrangements of internal organs. And we also can all think of situations in which someone might have an unexpected excess of a certain hormone given their body, or less of a hormone given their body, or maybe they have plenty of hormone, but their receptors don't know what to do with it, right? So we might think of like PCOS as an example of an excess of testosterone in someone who may or may not want that excess. So even when we're talking about sex assigned at birth, the reason I sort of belabor this point is saying that when we kind of boil all of this information down and we just say M or F, we're doing a lot to sort of take all of this information and just sort of, it generally looks kind of like M, or it generally kind of looks like F if we put all of that stuff together. It falls kind of in this range. And the crazy thing, when you think about it, is that based off of that, we've decided to set up an entire society. We kind of package all of that information and we give you a label, and that is supposed to set you up for life. So sex assigned at birth is actually more complicated and more of a construct than we like to maybe think it is. We think of it as absolute, but there's a lot more gray area there. and gender certainly is a construct that we've all invented as a society over centuries. Are there any questions about this at this point? All right, then. So I think it was Lisa who said, okay, so we know some of this stuff, but what do we do with it now? So let's get into that. So how, in your practices right now, before I get into specific examples, how do you see this? This is supposed to be an eyeball. How do you see this showing up in your practices? How has this come up in the exam room or in charts with patients? How does it impact your relationships with patients?
For me, I'm pediatrician, so for me, it's I'm gonna be learning a lot here today. I'm in that early phase, I think, and so what I've noticed is that I'm having more teenagers coming out to me, but not to their families, or some have express it to their families, and then they will like tell me, I prefer for you to call me this way, or um um so I feel that I'm seeing more comfort in speaking about it to their providers, and and to their families. So that's what I'm seeing.
Yeah, thank you so much, Nicole. And I know, from a lot of the conversations I've had with colleagues that you are not alone in seeing this more and more, and particularly in younger folks feeling more comfortable voicing this and having words for it, which, as I introduced myself at the beginning, trans wasn't even on the radar when I was a teenager. I had no idea that that was an option or that ever could be an option. And in my wildest dreams, if I ever did imagine it, it really was so closely associated with a life that would, lead to homelessness or drug use. It was clearly, if I were to go, to make that big turn in my life, I would be turning my back on my family and going into a very unsteady future. And so as someone who's, grown up and seen the changes our society has made, it's wonderful to hear those stories, but it also means that medicine is a little bit behind the times, and you probably weren't adequately prepared for some of those conversations. And so that's why we get to have these conversations here. So what are some of the things that are involved in coming out? What does that phrase even really mean?
It means providing a space for the person to feel comfortable describing themselves and how they want to be described.
Yeah, it's a person saying, I now have the words and I want to share the words in terms of who I am. And depending on whether someone's coming out and sharing their sexual orientation, then it's, I now have words to describe who I am and who I want to be with. And if it's more on the gender identity side of things, it's, this is who I am, this is my gender, right? So it sounded to me, and Nicole, correct me if I'm wrong, but it sounded to me like you're hearing more and more of teenagers coming out in terms of like trans identities and gender identity. Is that true?
Yes, and also in their sexual preferences as well.
Okay, so both.
Yes.
Yeah. So it's describing who I am, and as Nicole mentioned, sometimes people are going to feel more comfortable telling certain people before others. So you as the provider might be put in that situation. So what are some things that a patient might ask you to sort of change about their care when they've come out to you, or that you might want to think about doing differently or asking them about?
The first thing is, this is how I like to be called now, so I'm not Jaden, I'm Aiden, that kind of, name change is the first thing. And I go by he, his instead of she, her. And so immediately we flag their charts, and, I can't formally change it, But I can flag the chart saying this is how we're going to address this patient from now on. That's usually the first change.
Yeah, those are really important changes. So we talked about how names are one of the ways our society decides to, categorize us or help us understand which category to put each other in. And so frequently when someone's coming out and expressing a different gender identity, a name change will be part of that. And also saying, I use these pronouns now. So commonly we think of pronouns like he, she, they, although there are several others. Okay, and documenting that in electronic health record is really helpful. It is a challenge, I know, and some electronic medical records are closer to this and some are a little bit, lagging behind. But documenting these and sharing it among the other healthcare professionals can be a huge sigh of relief for patients. So I'm really glad to know that you do that. So what else might be different about a patient's care after they've come out and told you that they're transitioning or have transitioned? What are some other things that are on your radar as their healthcare professional?
Hi, my name's Emily. I'm a family physician in the family medicine residency in Lancaster. So I do inpatient adult medicine. I deliver babies and I do outpatient care. So when I joined the practice, they allowed us to change our bio about some of the, not only like the age of the patients we see and some of like our expertises, but I also had the opportunity to put like LGBTQ affirming. I'm also married lesbian and I'm out at work and mostly to patients as well. So I found that a lot of my new patients were coming to me who were LGBTQ. Some people were interested in like gender affirming care, but other people just wanted like an affirming physician. And so I found a ton of that. So a lot of people who did not even want anything like queer healthcare, they just like wanted me to be able to use their pronouns or like give them their acne medicine or their blood pressure pills with some respect and dignity. But I think the other thing, I have a guy in his 50s who recently came out as gay, and he came out to his former family physician who had been with for decades, and the physician just would not talk about any of this, would not engage. And so when he came, we talked a little bit about his identity and his sex life and how that's changed. And we talked about PrEP, and the former physician could not even engage in like a sexual history and how his needs might be changing. Not even like to talk about it, let alone like provide the care or refer him to someone who could provide the care that he might need. So that was a long story to say, like some people's needs in regard to their like sexual health, like preventive screenings or STIs treatment or things like PrEP might change depending on their, I guess, sexual activities, if and when they change.
Yeah, thank you for sharing all of that. I'm really glad that you're a resource and someone who's there for the community. You did share a lot of wisdom there that I want to highlight. And one of the things that you mentioned sort of right off the bat was just the importance of what we might refer to as the social transition steps that someone takes. So changing their name, changing their pronouns, dressing differently, those things can be even more important in some cases than you knowing the exact right, dosage for a hormone to prescribe or things like that. That, goes such a long way and gets you so much grace if you are able to use someone's affirmed name and affirmed pronouns. And so I really want to commend you, Emily, on sort of mentioning that and noting that for everyone, emphasizing that. Preventive care measures might be different. I know I'm speaking to a lot of family practitioners and a lot of pediatricians. And so basing your preventive care on sexual activity, not necessarily identity, but sexual activity, and being open to lots of different ways of exploring sex is always going to be important. And the same is going to be true potentially for body parts, right? So certain body parts need preventive care and others, not so much. So when we are talking to a trans person potentially who came out to us or a non-binary individual, and you're establishing care, and you want to make sure that you're following the right preventive medicine guidelines, how do you ask about someone's body? Has anyone developed sort of a script on how you find out what body parts that person has, so that you know what preventive screenings to offer?
I've been asking my trans patients that question because I find that the most challenging thing is to be inclusive, but to find the right words. And they say, just say it. They say, just ask. So I'd like to hear what you think.
Well, so what does it mean when you just say it? Like, can you just start us off by giving us, some way of introducing the conversation?
I'd like to give you the best care possible. Thank you for reviewing your sexual and gender identity today. Let's move ahead to some prevention. Why don't we talk about the parts that you were assigned at birth, or I don't know, you tell me.
You're doing great. That sounds awesome. So the first thing that you did that's a wonderful thing here that I want to highlight is you're focusing on their care and their medicine, because there's this thing, this is sort of an aside, but it shows up all the time. It's called trans broken arm syndrome. And I don't know if anyone here has heard of it, but it basically is just a term used to describe this phenomenon that trans people and non-binary people have sort of unfortunately gotten used to, whereby our care gets all wrapped up in the gender identity stuff, and someone who's cis just gets normal care. So this sort of trans broken arm syndrome kind of comes from this concept that a cisgender person goes to the ED with, arm pain, gets a brief history, an x-ray, and leaves with a cast. A trans person goes and gets, an invasive sexual history, maybe a, general exam, questions about whether or not they've had the surgery, questions about, well, could it be that your hormones are making your bones weak and that's why they broke? And it sounds like I'm being hyperbolic, but all of these things have been documented that these happen. And so what I really love about what you said there, Lisa, was that you started with, I want to give you the best care possible. And so let's talk about your body parts. I need to know which body parts you still have so that I can keep them healthy. And if there are terms you would prefer that I use when we talk about your body parts. So I think you basically nailed it. I think keeping the focus on the medicine, explaining why you're asking, and that you just really need to know which body part someone has so that you can keep them healthy. So beautifully done.
I also will sometimes try to say, like, I usually have a sentence that's like, I'm getting to know you, you're getting to know me as your physician. There's a lot that we're going to learn about each other as we meet over the next few appointments. At some point, I think it might help for us to have a conversation a little bit more in detail about anatomy and about your transition. But we don't have to do that today, and allow people to then choose, like, if I'm the person they want to tell those things to and when they're going to feel comfortable doing that. And then, because like I said, I have a number of trans people who are like, you don't need to know any of that because someone else is handling all of that care. Like, can I please just have my retinol? Thank you.
Yeah, no, it's a great point. Yeah. And once again, I think context really matters here. If this is someone you're establishing a longer term relationship with, then you've got some time and you don't have to, find out all of their body parts and everyone they've ever had sex with. But if they're coming in for a specific complaint, maybe vaginal discharge or something, you're going to have to talk about those body parts. But you can, make sure you're explaining why, so that they're not guessing or not wondering if you're asking out of your curiosity. And then just offer if there are any terms you'd like us to use other than the, medical or anatomical terms. I think that's a really nice thing to offer. Something that you might start seeing if you haven't already in various electronic health records is something known as an organ inventory. I don't know if anyone here uses that or has heard of that. Maybe not. I honestly think it would be helpful. This almost goes to Corey's question a little bit of, what part of what we're talking about here has to be specific to trans or LGB folks, and what of it is just, being a nice human and taking care of everyone. I think organ inventories, I think we could workshop the name a little bit, but besides that, I think the concept behind organ inventories is great for anyone. And what it means is what it sounds like. Basically, you have, whether it's an anatomical schematic or just a list, you just list out organs that some people have removed for various reasons. So if you're focusing on gender transition, you might list things like cervix, uterus, fallopian tubes, ovaries, breast tissue, penis, scrotum, testes, those sorts of things. But as everyone on this call knows, there's other reasons that you might have a hysterectomy besides gender transition, which is why I think it actually would be beneficial if everyone had one of these in their chart that was easily accessible. But one reason to do this is so that you have documented in the record, okay, this person doesn't have a cervix and they have no history of abnormal paps. We don't have to ever do a pap smear again, yay. And you don't accidentally end up, sending them a reminder for something that they might really not want to hear about ever again, right? So organ inventories is another way in a medical record to document that information and to help guide you as you choose which preventive medicine you want to offer and which no longer apply to someone. One of the things that we were hoping to talk about now that we've laid the foundation is, I know a big passion of this group is pregnancy-related care and intra-conception care. So let's talk a little bit about pregnancy and how that might differ or be the same for folks who identify as LGBTQ. So anyone want to start us off with just, maybe some ideas of how a pregnancy from conception through, the 4th trimester might look different for someone who's in the LGBTQ plus community?
I'll just share a humorous anecdote. So I mentioned before, I'm a cis woman, I'm married to another cis woman. And after anyone gets married, you have to start asking them when they're going to have children. And multiple people mentioned surrogacy and being a gestational carrier for us. And as a way to be we're hip, we understand that you guys are gay. But we always want to be that we're full up on uteruses. We don't need any more of that. We're good on that part. So I think that the family building for queer people is always really individualized. And I think there's been a swing in public of understanding that people's plans to have or not have children and when they're going to do that can be really personal and private. I think it's becoming a little bit more understood that we don't just ask about everyone's plans. And I think including queer people in that of how someone's going to have their family, if they're going to bear children or adopt children, is very individual and personal.
Emily, I relate to that story very much. Yeah, so I think, again, it kind of goes to Corey's point of isn't this just, something that we would want to care for everyone? And so I think it is becoming more hopefully normalized for everyone, whether you're in a straight relationship or a queer relationship, or you're trans or cis or non-binary, that how you choose to create a family or not is up to you. And that's some of the core tenets of reproductive justice. And so we're not making assumptions, hopefully, about how anyone would go about making their family or choosing not to make their family. But this is definitely something that LGBTQ people, I think, face at a higher rate, which is people assuming we can't have families or we can't have biological families, or assuming that there are, components involved that aren't necessary, like, requiring IVF when that's not really necessary, or being kind of confused about how that all works. So it's going back to first principles. We know we need some sperm, we need an egg, and we need a womb to grow a baby in. And as long as those pieces are assembled in some way, then a family can be made. So that's a really good point. one thing to note about pregnancy that might be different here is how someone might go about creating their family. What else might be a little bit different, or we might want to think about?
What we're calling everything, the names for parents, the names for pregnancy, the experience of pregnancy or conception.
Yeah, so I mean, vocabulary is a sort of a big one here. I work in an OB/GYN department, and I can tell you lots of things are gendered that never really needed to be gendered. They just kind of became gendered. And, so things that are just have become the norm is just saying mom or mama, or saying I'm going to go see her, check her. It just has become sort of part of the background noise. And so it's just assumed. And so a lot of the vocabulary that we use in pregnancy is focused around the concept that it's a mom, that it's someone who identifies as a woman who's married to a dad who's in the waiting room with the cigar. Those, times are changing, but some of our language has really not kept up. And so those are things to just, run through your mind and maybe practice saying pregnant people. Like if that's going to be uncomfortable for you the first time you say it, it might be good practicing it out loud, or, parents instead of mom and dad, those sorts of things. So that's definitely going to play a role here. What else could be a little bit different that we should be aware of? So I think along the same lines as sort of vocabulary in terms of like what we call everyone, I think also recognition that, it's not necessarily someone who identifies as a woman who's going to be pregnant, right? There's some groups of trans men who deliver or carry pregnancies for their families might use the term seahorse or seahorse club. Does anyone know why?
The male seahorse carries the fetal seahorses and
Yeah.
expels them into this world.
Yeah. So seahorse is a symbol that you might see for trans men who carry children for their family. So it's first of all important to know that, and I'm sure you all know this, but just to reiterate that just because someone's on testosterone doesn't mean they cannot get pregnant. However, we do not want someone on testosterone to be pregnant and stay on testosterone, right? Testosterone is a teratogen. And so just testosterone itself will not stop someone from being pregnant, but that will alter, their treatment plan if they choose to stay pregnant. As long as there is a functional uterus, tube, and ovaries, and someone is having sex with someone who produces sperm, that can result in a pregnancy. And so we just need to keep that in mind if we're talking about contraception or we're talking about desire to have children, and talk about what that might look like for a couple. Absolutely. So I think when we're thinking about having non-binary trans men deliver, or talking to them in the postpartum period, or thinking about helping them with family planning in between pregnancies, I think a lot of this goes back to that sort of first principle that Emily helped us with earlier, which is that a lot of it, if not all of it, is really going to be about how you talk to someone, talk about someone, and show that you respect who they are. So a lot of it is going to be names and terminology and, showing respect by using the right name and pronouns. But the actual pregnancy care is pretty much exactly the same, regardless of who the gestating parent is. It's really just about how we treat someone during that time period. And similar things are going to be true in postpartum visits and interconception care as well. It's demonstrating that you respect the person for who they tell that they are in terms of gender, but not that you want to treat them entirely differently medically because of that. So at this point, we've had some people jump on and off, but we do have like 9 minutes left. If people have questions, I want to pause, and if you have questions that have nothing to do with anything we've talked about so far, I want to give you an opportunity to bring them up, and we can chat. Anything?
Can you hear me then?
It's really faint, but I can kind of make you out.
since I'm in peace, like I think for me, what's more relevant is their mental health. You know, because they're, like I said earlier, they're like, you know, we're in the early stages of coming out. We haven't really expressed it to a lot of people, and a lot of the times it's in a visit where we're also addressing mental health.
Yeah.
And so, do you want to talk a little bit about that?
Yeah, sure. I would love to. Mental health in some ways can be a thorny subject because I think, well, I know that for far too long, part of pathologizing transness or people who are beyond the binary is to refer to it as a mental health, you know, pathology in itself, right? That's where a lot of the roots come from. I mean, it wasn't really that long ago that homosexuality was listed in the DSM. We are only now moving away from characterizing or categorizing being trans as a mental illness and towards something more akin to a hormone imbalance, right? Something that is a little bit more biological than it is mental illness. And so I mention all of that not because mental health isn't important, it's wildly important and incredibly relevant to what you do, but just that if you find resistance to talking about mental health or therapy or getting help, it might be because people are so concerned that they're going to be lumped in as just, oh, they're just mentally ill and that's where this is coming from, that I think it caused a little bit of resistance. The real reason that mental health is so important is not because there's any innate connection between being trans and being depressed or being trans and being anxious. It's because of all the outside forces on someone who is, you know, other, you know, and that could be other in lots of different ways, but in this case, being LGBTQ. And so as a result, when you're a pediatrician, I imagine you know this, but we have studies that demonstrate a 93% reduction in suicidal ideation and anxiety and depression in high school when children grow up in a home that invites them to be who they are and allows them to express themselves. I mean, that's massive. If there was a pill that had a 93% reduction in teen suicidal ideation, it would be, you know, selling like hotcakes. So the thing that is most important when we're talking about mental health, I think, is not just to focus on the individual who's coming out or talking about their transition, but if we have the opportunity to influence the folks who surround that individual, helping them see that their support is really the silver bullet here and can go, you know, much further than medicine or therapy can for the individual person per se. That being said, we know because of all those external forces that trans folks, non-binary folks do have higher rates of depression, anxiety, suicidality. And so destigmatizing mental health care is really critical. I think one of the best things that you can do as physicians who are not in the mental health field is know who your local referrals are and who is actually gender affirming. Because I think the last thing you'd ever want to do is send a teenager or an adult to a therapist who behaves the way Emily described that other family physician as, right? Going to a therapist who's going to try to talk you out of your transness, say it's a phase, or say, you know, it sounds like your depression is the big problem. We can talk about all that later. You know, that's really not what you want. So I think the number one thing you can do is make sure that you know that when you refer your patients to someone, that they are gender affirming and that they understand that a supportive environment is the biggest opportunity. I want to invite Corey, if you want to expand on what you said there, because I think it's connected to what we're talking about here. But I think understanding who your referrals are is pretty important. Corey, are you able to expand on it, or are you kind of?
Sorry, I was having trouble coming off mute.
Yeah, no problem.
Yeah, I just think that it's unfortunate that we don't have enough mental health support for all the mental health needs that we have, and there's a part of me that thinks that everyone needs a mental health. We need to have opt-out mental health for most of us, myself included. But we lack that resource, and I think as primary care doctors who are family doctors and pediatricians and so forth who are who are attentive to their patients, they're probably providing, and we probably have the opportunity to provide as much mental health support as, like Emily said, there's a risk in referring to others. You don't know what you're going to get. And you don't know how long it's going to take your patient to get there, and whether or not they're going to be able to follow up, and co-pays. And there are just so many barriers that I think a good family physician can overcome by being attentive and knowing and saying, I'm available.
I have hour-long appointments with my therapist, Corey. Are your appointments an hour long? Can I get an hour of your time?
I have a colleague who says, mental health care therapy is like flossing. We should all probably do it more than we do. So I couldn't agree more. My wife's a therapist, in full disclosure, so I am very pro mental health care and therapy. Is it Stephen? Were you hoping to weigh in?
Yeah, I just wanted to say I feel that there is a very, very dark cloud coming politically in this country, with 25 states enacting laws that make it difficult not only to have abortions, but also to provide gender affirming care. So I wanted to point out that the last two issues in England Journal and the Sounding Board, there have been articles of the University of Michigan who've really laid out in detail how this is impacting us as clinicians, our patients, medically, legally. It's just crazy. So I don't want to sound too ominous about this, but it looks really challenging for all of us for the next 6 to 12 months and thereafter.
Yeah, so one way our residency has responded to recent developments is that we have created an opt-out program for new interns. So they are going to be offered a mental health counselor visit, and they have the opportunity to say no should they decide. But I think that kind of option has long-term, credibility, and I think that legislation, I'm thinking a lot about gun violence nowadays, and I know that a lot of the solutions, I know that's far off of today's topic, but the solutions are going to include access to mental health care, and I think that funding for that is so very vital. I'll stop talking now.
I know we're nearing the end of the hour, and so if people have other things they need to go to, I will not be offended. But I do see that Stacy, you've unmuted. If you have something to ask or add.
I did not. I'm so sorry.
Oh, that's okay.
This has been really great.
Well, it was lovely hearing your voice anyway. So, thank you so much for having me, and for, being here on a Wednesday evening of all times, and letting me sort of, use a whiteboard method, which is a little unusual for these sorts of talks. But I really loved hearing from you, and hearing about what kind of great family physicians and pediatricians are out there that are really doing this work. So thank you for everything you do. And I can put my email address in the chat. So if you have a question that we didn't really cover tonight, or just want to be in touch now or in the future, please feel free to reach out to me. I'd love to hear from you. And if you want to hang on, or you have other questions, I can hang on for a little bit. But thank you so much for your time.
Thank you so much, Dr. Lynch. This was really great, and I'm glad a lot of people got to engage, and I'm looking forward to what this is going to bring out for us as a network. But I wanted to thank everybody for taking their time out and participating in this session. And again, thank you, Dr. Lynch, for helping us here.
Happy to.
All right. Well, if you don't have any additional questions or comments, I will excuse you all. And have a wonderful rest of the evening and week, and we'll be in touch soon. Thank you.